just keep going. Alex, why are you starting a practice? You're insane.
Okay, let's get started. Welcome, everybody. This is Alex Mohseni. Welcome to Mastering Medicare. Today, we are in late April 2020, and Amy and I are doing a special episode here.
We're losing our minds.
We're losing our minds. Yeah, so we're actually starting something kind of new, which is I've decided to start my own telemedicine medical practice because I see a certain opportunity that I want to take advantage of and use my expertise. And since I've been doing telemedicine for kind of other companies, both in a clinical and admin role for a number of years now. And anyways, what we're doing today is I've never built my own practice, and Amy has. And so I have a lot of questions on how to build my own practice. And so I'm going to be asking Amy for some help.
This is like a Q&A of like how to start a Medicare practice.
Yeah.
Anyone wanted to learn how to do it, this is going to be like 15 sessions of how to do it. Just kidding. We're going to do this in like 4 minutes. It's so freaking easy. I don't know why we even like thought this was going to be more than 10 minutes.
Well, it's actually kind of tricky.
Long. It's going to be so long.
Yeah, no, it's actually kind of crazy. So, so I guess the background here is that up until COVID-19, most Medicare patients could not get access to telemedicine unless they were living in a rural area, meaning a non-metropolitan statistical area. So basically, nowhere near any city. They could not qualify for getting a telemedicine visit paid for, which is kind of crazy. And obviously, with the lockdowns throughout the country, that's not a viable rule. These seniors need access to care, and so CMS, in their infinite wisdom, finally caught up with the 21st century and said, okay, you guys can now get telemedicine from your home, and we'll pay the doctors to do it. So in our discussions with many kind of practices out there, we've realized that most primary care doctors have simply not been able to deploy a telemedicine solution. So a lot of these seniors feel abandoned right now, and they're not able to get the care they need. So Amy and I were talking. I said, well, I know how to deploy telemedicine. Why don't I just create my own practice?
Yeah, no, and let me tell you why I thought this was a great idea. So the reason I thought this was a great idea is because most of the telemedicine sort of like on-demand type of platforms really are trying to take care of anybody from like 1-year-old all the way to 101 years old. And there's sort of no expertise, and they're plugging in people who are having to sort of straddle the age range. And I was really excited when you said you were going to do this, because I thought, oh my God, it's completely focused on this one group of people. And I think that's where there's no expertise right now. There's no expertise in someone saying, oh, I know how to take care of Medicare patients. I know what they can and cannot get. And it's like a super niche kind of telemed product that I had not thought of. Because I mean, all these, whatever, doctor on demand, and, you know, not there's anything wrong with them. It's just that they don't appeal to the population that is clearly at the highest risk right now, which is they probably to the doctor or shouldn't go to the doctor, even if this all opens up. I mean, until there's a vaccination, I'm not really sure that seniors are necessarily supposed to leave their house to some degree, right? Like they're not going to want to leave their house. And a lot of the rules have opened up so that people have access to certain services, even if they're not homebound anymore, because the risk is so high. So like Medicare has said, oh, you meet homebound criteria for home health, even if you're not actually homebound right now. So what I was excited about is that you said, all right, I'm going to do this for Medicare patients, telemed. I know how to do this. I can set this up. And it was very appealing to me that we do this sort of like how Alex started a practice.
Yeah.
Because it is kind of funny how hard and how challenging it might be to start the practice and then figure out how to market it and figure out how to like develop a real niche telemed product that could be for any state in America because you have a license in every state.
Almost.
Oh,
Yeah.
well, all right, fine. I'll give you like a little bit of street cred.
45 or so.
Yeah, whatever.
So
So basically, I was really excited about this, and I said, we should really video this, and we should really like talk about what it is to sort of
right,
pivot quickly, start
right,
a practice quickly. I mean, these rules only came out like 2-3 weeks ago, and let's see
right.
how fast someone can create a new product and bring it to market and see what happens with that. And you're a real expert, and I've sort of done the beginnings of starting a Medicare practice, so I figured let's do it.
Yeah.
All right.
And so let me recap kind of what I've done thus far and kind of the help I need from Amy. So
Yeah.
I already had an LLC set up for
Which is a company. Basically,
yeah.
an LLC is a company. You started a company to do this.
Yeah, and I had that with my EIN number and a bank account and
What's an EIN number? Just for anybody who doesn't know, it's like your tax ID number.
yeah, it's your tax ID number. You go on the IRS website, you get it in 5 seconds. You just got to make sure you save the document they give you because it's almost impossible to ever get it again. But whatever. So I had that already.
Screen, and you're like, oh my God, I got to write this number down.
But that's all I had. So what I did not have was I did not have an EMR. I did not have a billing process. I did not have my enrollment in Medicare set up properly for this. And so MedMal, yeah, MedMal. So each of these has been a really interesting challenge, and so I have a lot of questions for Amy. So we're going to go through some of these as I
answer them.
Yeah.
But wait, I have questions before you start moving forward. I have some questions for you.
Yeah.
Number one is, how did you figure out? Because I think this process is actually kind of fascinating. If any provider was out there and they were like, I just need to get medical malpractice insurance, I want to start a telemed practice. Like, how do you even start that process? So what did you do?
So what I did was just like buying a house where you have to use agents. When you want med mal insurance, you got to use some sort of broker. You don't like yourself call Lloyd's of London, and say,
I would like to insure myself.
I would like to insure myself
against all telemedicine lawsuits. Thank you. Send me a quote for $10.
Okay, sir. No, yeah, it doesn't.
Yeah, no, that's not happening. So you had to find an agent, and
a broker.
We kind of found an agent. We found.
Well, I asked Amy, who's your broker, and she told me Ron something, and he's been awesome. Yeah. And if you don't have one, you can always check with your local medical society. And yeah, ding. Ding.
Thanks, MedCai. We paid our dues this year.
Yeah, big shout out to MedCai.
Yeah, shout out to MedCai.
So actually, this has been super painful, and it's not Ron's fault. Ron is an awesome guy, but getting MedMal insurance requires you to fill out these forms that look like they've been rescanned 100 times over the last millennia, and
they ask your name over and over again.
Well, not just
you went to,
not just that, but like. The minutiae of what they ask, did your grandmother ever bake beef stroganoff, or like they want every single detail of anything you've ever done, and it's really painful because it's on these crappy forms, and then each of the different companies does it in their own way, and it's just for anybody who's kind of a younger person used to streamlined user interfaces. It's just a horrible experience. It's absolutely horrible. And actually, during this process, I went back to the broker and I said, you got to be kidding me. I mean, this is like a 50-page application asking the same stuff I've already said over and over.
And there's a national database for half the stuff that's been asked.
Yeah, has nobody come up with a better way? I almost abandoned the medical practice and said, let me just fix this problem of applying for MedMal, because this is
entrepreneur. You're like, I got to fix every problem along the way, because we know you have like literally visceral pain. But wait, I think it's important that everyone understand what the MedMal sort of like ecosystem sort of looks like. Yeah. So there's tons of these companies out there that insure physicians. Some of them are big national companies. Well, there's not that many, but there's a lot of national companies. And then there's like state-based companies. Like in our state, we have a company that insures, let's say, you and I used to work for the same emergency medicine practice, insures the emergency medicine practice
Right.
groups in the state. And then they also insure OBGYNs, but they have a real penchant for brick and mortar types of practices. And this idea that there's going to be, hey, I have like a unique practice, all I want to do is telemed, it sort of forces you into the national marketplace, which is why you really need a broker, because they know all the big national companies, but each of those national companies have their own application process.
Yeah.
It's not like it's not like applying to college where it's like one application and then you just sort of like shoot it off into the world. Right. You have to literally ask each single company, hey, listen, this is what I want to do. And this is also so new. So it's kind of hard for the what are those people called who like evaluate insurance, all the claims,
yeah,
and whatever those people are called, those mathematician type people, they probably don't really know how to ascribe a risk to something like this.
Yeah.
Because there's no historical data really.
Yeah.
So
yeah, if you don't fit neatly into their box.
Neatly. I mean, when I started my house calls practice, this is exactly the same thing. They were like, house calls? Like, we don't even, like, there wasn't even a question on the med mal thing.
Right.
And the funny thing, they're like, oh, so you're a home health agency. No. I am not a Medicare home health agency. I am a physician practice trying to do house calls, which is totally different. And actually, the thing that I learned really at the beginning was that the local carrier, the local insurance carrier that covers like emergency medicine practice, internal medicine, and all the typical ologists who are out there in the world in Maryland would not insure me.
Yeah.
They were like, we don't even understand what you do. We can't figure it out. And you're not brick and mortar, and see you later. So I did have to go out into the national market, which did force me to have to fill out form after form after form, get a bunch of quotes. And they were disparate, like, oh, $8,000 for the year, all the way up to $30,000 for the year. And that's a teaser rate. And then the next year it goes up by, it doubles. So that you have these intro rates, because the way that medical malpractice looks at you is that, you don't get many patients in that first year. So they're not really insuring you for that much in that first year. But then because most med mal insurance policies do you can sue somebody up until 3 years, 72 months, right? Like you have 72 months to sue a doctor unless it's
depending on the state, but yeah,
depending on the state. So, you want somebody that's going to be able to say, all right, so each increasing year up until you're full, you don't have a mature policy. So it seems like a teaser rate. And then each year it gets more and more. And then you have to say to yourself, oh my God, do I even want to start this practice? Right? Because if I hate it and I don't want to do this, you still have to pay the tail, which is usually 1.5 times the maximum amount that you paid in any given year. So that if your worst case scenario, at your most mature rate, you were paying, let's say, $30,000 a year because you had a mature policy, you're going to pay $45,000 to just get out of that. Like oh my God, I made a mistake and started this dumb practice. I don't even like it anymore, but you were paying $30,000 a year in your med mal insurance. You're suddenly now going to have to pay $45,000 just to get out of it. And
that's the big risk here. That is the big risk.
I actually think that is probably your biggest financial risk here, because the cost of getting an EMR and paying the billing company, and you don't even have a brick and mortar because you're doing telemed, it doesn't really, it doesn't, you don't even think about the med mal insurance in terms of getting out of it. Like, it's easy to shut down a business, right?
Yeah.
Oh, great, off, shut down my website, shut down my EMR, shut down any vendors that I had relationships with. This is the priciest vendor that you're going to have a relationship with. And
the real risk here is that, Medicare is only allowing this to happen as a temporary rule change. It could be that in 3 months and 6 months, they say we're snapping back. Yeah. And the whole thing
risk.
Could,
you're
that's
just
the risk.
Full at risk for the med mal. This is your biggest financial risk. Have you gotten any quotes back yet?
No, I submitted all the paperwork. I think it was 2 or 3 days ago. And obviously it takes them a little while to
figure this all out,
socialize the application, and get the actuaries to pull out their pencils.
Yeah. Where's my envelope? How much risk is Alex? So that'll be interesting to find out, and we'll keep our listeners up to date on that. So you got your MedMal. Okay, so you've got your MedMal apps out. So that's exciting. And then
Yeah.
with your Medicare? Remind me, we were talking about like you're just one guy. Are you like a practice?
Yeah, so here's the complexity, right?
So what ended up happening?
So you have to be enrolled in the Medicare MAC where you want to practice, right? The MAC is the company that
Novitas where we are,
yeah,
but it could be Palmetto, it could be
right,
CGS, it could be all these other different companies that sort of like own the regions of the United States that sort of manage the Part B application and payment process
right,
for Medicare. They're private entities that sort of manage kind of like a private insurance. They just sort of manage the
right,
whole enrollment and payment and stuff for Medicare. So
yeah,
we're Novitas where we
right.
sit. Yeah.
So I reached out to Novitas because what was actually difficult to understand is, there's actually three or at least three different kind of entities here. There's me as an individual physician, right?
Right.
There's
You have
my
your NPI number as an individual, which follows you around for your whole like medical life
right.
career. Yeah.
Then there's the LLC, the company,
Yeah.
right? And
Right.
that itself has an MPI number, which I had to get. And
Yeah.
that was tricky because what they're used to doing is giving you either an individual NPI or an organizational NPI. But when you try to get an organizational NPI, they specifically ask you, is this a sole proprietorship? And so, what do you answer there? Because from the perspective of, yes, it's a sole proprietorship in that I am the sole individual who owns it,
But you have an
but
LLC.
it's an LLC where I'm going to have other employee providers working underneath of it. So what do you actually mean by that question? That was very frustrating to work through with
Right.
them. And because the NPPES who runs the NPI thing, their purpose with the NPI might be a little bit different from what Novitas and Medicare mean by an organizational NPI.
And if you became an S corp, because some people take their LLC and turn it into an S corp, and then you're like, wait, am I a corporation? Am I an LLC? Am I a sole
Yeah.
proprietor? Yeah.
So
Like it becomes a tax question, sort of.
Yeah, so I got an organizational NPI even though I'm the sole owner because I think that's what they intend me to do. And I called Novitas and I ran it through them, and they seemed to agree with me. And then it was a question of, okay, do I need to enroll the LLC itself with Novitas, my Mac, or is it actually just editing my current? And the answer that I got from them was actually surprising. They said, no, don't enroll your LLC separately. Just add it to your own individual enrollment. And that is not what I expected. I hope the lady I spoke to knows what she's talking about.
Call back again.
Yeah.
Get a different answer. But that is the problem with some of these. Everybody does. It's all about how they were educated and trained sometimes. I mean,
right.
Like the worst case scenario, I think you can move stuff around. I think you can just rejigger stuff, even if it isn't done the right thing, because you go into this process called development, and then your development person is usually a really good person. So like if you do end up sending in the application and you're like, I just didn't even understand what you were asking for, because sometimes they ask for old information that you may not have access to, and you just sort of like, all right, well, maybe I just won't put anything in like section 4B and see what happens. If you go into development, they will then say, listen, this is what we need, this is what we need, this is what we need. And it may delay it. But Alex, what did you learn? Are you able to, even though you haven't gone into development or haven't gotten approved by Medicare, could you start seeing patients today?
Well, that's my understanding, that I can start seeing patients today, and then once let's say they approve,
they'll retro.
Then they can retroactively essentially apply. But I guess the underlying issue that we haven't explicitized is that when you have employee providers working underneath of your organization, you have to route their encounters kind of through that organization so that Medicare knows you.
Yeah, through the umbrella organization.
Yeah. that so that the Medicare knows that, okay, you guys are operating as one practice, so that, because there's certain codes that it matters. Like if I try to bill something for a patient whom one of my employee colleagues saw already, be linked, because now it's an established patient of the practice, right? So you're
Right.
trying to basically make these connections between the different providers and the organization. And it really shouldn't be that hard, but they've made it really confusing, you
And
know?
yeah, and the Medicare numbers are make no, like, it's just, it seems like someone just took an alphabet soup and just went bleh, that's your Medicare
Yeah,
number, and then somebody else gets a bleh. They don't really make sense. So basically, just to summarize, if you start a practice and you decide, okay, I am like, not just me, but I'm a company, anybody that comes to work for you has to, they use their own NPI number, but it gets linked back to your
yeah,
Medicare number. And that is, you just have to make sure, because I actually had this happen, where I've employed people who worked for other companies,
right,
and it was found out later somehow Medicare was sending, like, Washington Hospital Center all their stuff, and we couldn't reconcile it. We're like, where's the
right,
payments? And you would call Medicare, like, we paid, and you're like, actually, it was the secondary payments that got screwed up, but that's a whole
mm,
other problem. Is that the secondary payments, somehow that didn't get coordinated within Medicare, and they were sending all the secondaries to another employer that
yeah,
they also worked for. So you got to kind of keep your eye on that ball, because if you don't get any secondary payments from some of the stuff, you have to kind of chase that down a little bit, because that's
right.
fun. There's nothing more fun than chasing down money.
Especially small
I
dollar amounts that are not worth your time,
know,
right?
like $12.50.
Uh,
And it's not
but if
like,
you don't, but if you don't solve it, then the aggregate value of that is huge, right?
correct. And I believe the aggregate value of one of these was this mistake, just, it was pervasive, and it was in the 6 digits. So yeah,
Yeah,
yeah.
yeah. So, but I will say I was pleasantly surprised that I was even able to get a human being from Novitas to actually spend, 15 minutes trying to work through my situation and understand it and give me advice. I just hope the advice is right. You
I,
know?
yeah, no, and I will tell you, my experience also with Medicare, and this is just a shout out to CMS, woo, that on the enrollment side, very helpful. They do want, I mean, I think this is an
Yeah,
improved system, but even, when I was first starting off, and I had to recreate it over the years for lots of different reasons. I had one name, and I had a partner, and then I didn't have that partner, and then I had to switch and then I had to sort of recreate everything. So I went through this process several times, and I was also very pleasantly surprised at how very helpful people were. So I
yeah,
want to, I don't want to badmouth the people. It's just the system is sort of screwed up, and it's unnecessarily complexified.
right,
Yeah.
right.
So then we got your med mal. Now we've got your med.
And I will say I was also pleasantly surprised that I could submit my application 100% online. That was nice. I mean, that's more advanced than the MedMal side. The MedMal side still had me doing stupid PDFs that were not actual online forms. Like, come on, man. Pay somebody $200 and convert your application into an online form. It's really not. I mean, it's come on.
It's bananas. But wait, I want to take an Alex moment. I want to summarize all the random things you need. So first, you needed to make an LLC, which you got
Yeah,
a tax ID number. Then you had to
bank account.
bank account, because you need that for your Medicare form, because they want
Yeah,
to do all electronic transfers. Then you had to get an NPI number,
right.
and then you
For
have
the
to, for
organization.
the
It's yeah,
organization, and then you have to get med mal insurance,
yeah,
and then you have to apply to Medicare, and you're going to get Medicare ID number on top of your NPI number
right,
for your organization, and a separate NPI number for you as an individual that links you to your own organization. And then anybody who comes below you will then also have to, with their own NPI number, get their own Medicare number that links them to your new organizational
right.
NPI and Medicare number.
Now, since I only added my organization to my individual one, this is where I'm a little unsure if I
Did you
got the right advice.
55B or an 8? You did an 855I.
Yeah, not an
Yeah. Okay. Yeah. I
855.
think that's the way it is. I think you do. And did you do an R too? Because the R then
Yep,
links. Yeah. So you do an I and an
yep,
R as an individual sole proprietor LLC,
Right.
still do an I with an R as opposed to a B, which is
Right.
like multiple owners
Right.
and stuff like that. Yes.
So I hope that's right. But it was an amendment to the 855 I already had.
Right.
Right. Because I
Yeah.
already had I
It's
had pre,
none
you
of
know,
it.
in my
Listen, you're gonna know when it works when the money flows.
right. So
You'll
we'll
know if it's
see.
successful when you see your first like $85 get ding, into your bank account. You'll be like,
Yeah.
success. So okay, so now you've gotten that, and so this process has taken. I mean, we have a habit of being like, all right, we've got a pro forma, we have a business idea, let's start the business in 24 hours. So it's been what,
Yeah.
like 4 days?
Yeah.
It's
Yeah.
been
Oh,
4 days.
for real. Yeah.
No, for real.
For real.
That's
Yeah.
the funny thing. That's why I was like, oh my God, let's stop for a second. Don't do anything else until we start our podcast. Because knowing us, you'll have started your practice and it'll be fully formed and like bringing in revenue in like 7 days. So
I
let's
hope
just
so. Yeah.
slow it down. All right. So the rapid pivot has happened. Okay. So you've got your Medicare. You've got, all right. So
So
now,
all of those are cooking, and now I guess it's the EMR, um,
right.
which so I was under the impression that, well, let's step back for a second. First of all, I am a true believer that getting the right tool for the job, even if it's more expensive, pays dividends in a massive way later on. So I spent quite a bit of time kind of talking to a bunch of people and researching, trying to figure out what would be the best EMR for what I want to do. And I know Amy had a lot of experience with Dr. Chrono, and I
Which I
personally have,
still love, by the way.
and I
Yes, I do.
personally have used eClinicalWorks. Uh, no comment there. um, and
The page is going to blow up. Thanks.
in our remote patient monitoring work, we've noticed that the practices who use Athena Health generally are just much more successful practices than those using ECW or almost any other practice. And I did look at Practice Fusion, and although it seems like you can just be up and running with them quickly, it seemed like their revenue cycle portion, you have to find somebody to connect to it, and um, it looked like the main feedback I could see from people was that it's a fine solution for the very beginning, but as your needs grow and things get more complicated, it's just not good enough. And
It's
um,
free though, right? I mean, that's the
it's
thing with Practice Fusion is like if you were to say, oh, that portion
yeah,
of expenses I don't really want to incur at the beginning.
yeah,
Although, but as a single provider, it's like give the range. I mean, it's like all the 150 to $300 per month. That's
yeah.
nothing.
It's
That's like
nothing, right?
free. I mean, that might as well be free to some degree.
Right. And I even saw a few kind of new, more modern ones that looked really good, but they were kind of more focused on the therapy behavioral health space. There
Right.
was a really good one. I think it was called Simple Practice or something like that. Beautiful tool, but not really designed for what I wanted to do. And so,
And wait, so just quickly, I'm sorry, but how did Athena Health and any of the choices that you were making have anything to do with the fact that you want to do telemed? I mean, did you look at how they
yeah,
like
so
their
Athena,
internal like how did you like how
yeah.
did that come up?
So some of these, like ECW and others, have their own telemedicine module,
Yeah,
whereas others, like Athena, they have an app marketplace where you can just add on these modules.
right.
And I really like that Athena allows that and basically wants to play ball with all these other vendors. Whereas some EMR vendors, the biggest one, which shall not be named for fear of lawsuit, it really doesn't make it easy at all for.
So is these APIs or are they all connected via API? I'm so tech
Yeah,
savvy. Like what else connect?
yeah. I presume they're using some sort of APIs to connect to. But so, anyways, I reached out to Athena and said, let me learn more about how you guys do it. And uh, it's rare that during a demo I actually get impressed.
Mm.
And they had a bunch of features that I had not really thought about, and assuming it's true, would be of great value. Like they've already integrated with many of the local health systems and CRISP, our local HIE,
Oh,
so that
nice.
as long as the patient's registered the right way, like all their recent discharge summaries and results and stuff.
Right in.
And so for my population, if it's a Medicare, more, a more elderly population, having that information automatically flow in, that's worth so much to me.
Oh my God, you don't have to go out there and start. I mean, it's almost like their past medical history auto fills in.
Yeah. And that's huge.
Which is actually the goal for every provider, no matter where you are. Like if you were sitting in an emergency department, let me ask this question, because I haven't sat in an emergency department for a really long time, but do Cerner and the big ones that are all out there, do they automatically pull in CRISP data? Or are you still going to the United landing page and having to futz about?
Yeah, it depends. Some of that data, I've seen it even with Meditech, they're able to pull in some stuff, but somebody's got to build the connection. And God bless CRISP. I love the folks, but
yeah,
but it's slow working with them sometimes, So anyways, that was really awesome. And what I'm trying, one of the things I'm trying to do here that I haven't said to you is to see, can a solo doc like myself set up such a streamlined practice that I don't need an army of office people? Can I even reach the pinnacle, which would be not to have a single ancillary staff person? Can the EMR and right? Because when I go to my friends' offices, oh my gosh, it's a disaster. One or two providers.
Of people, and they have an army of people. Just bull honky,
Well, the reason they exist is because the tools that the practice is using are suck.
Well, right? They also try to take a brick and mortar practice that was totally paper-based and transform it while they're moving at the speed of light. Right. Like offices, in order to just stay afloat, they might have a 50 or 55% overhead
easily.
And then so for them to transform, it's almost too hard. Like you almost want to just wipe the slate clean and just start. It's like cleaning out a closet, but nobody can afford to do that. Right. I mean, I think a really interesting, like when you watch practices that are brick and mortar, and that had this whole process, and they kind of get adopted into, let's say, like a Privia or something like that. That process, Privia does help so much with that because they know how to transform. But a small practice has no ability to do that because how is the doctor supposed to be seeing patients, billing and coding, scheduling and having all this stuff, and then at the same time be like, oh yeah, we're just going to just totally transform the way that we practice medicine. Not only just from like, maybe we'll think about like how much we're going to save the system and keep people out of the ER, like not that type of transformation, but literally a day-to-day systems perspective. It's impossible. So the neat thing is to watch somebody try and start this from scratch, because also the evolution of technology and even just Medicare rules and laws can change how you start from scratch almost every day uniquely at this point. Like what happened yesterday is like, maybe there's going to be a new CMS guidelines about how to do X, Y, and Z today. Right. I mean, so this is actually interesting. We'll see if you can manage to do that. You're the guy to do it, Alex, by the way.
I'm just fascinated. Like, can I pull that off?
So the one other thing that I thought was really interesting. So when I first started my practice, I thought to myself, why do we have to document with typing every single thing? Why can't the telemedicine experience be recorded and stand alone as the sort of the documentation of the visit itself? Like, could you just take the visit, transcribe it, and be like, all right, I'm done. This is my documentation. What I said is my documentation. Yeah.
Well, that is essentially what we do at SiriusMD, but our conversations are text-based. But now we're in a lucky position there because we're not doing fee-for-service telemedicine, right? We have our own special contracts with the payers where we're not billing individual encounters, so we don't have to meet the 5 HPI and all the 8 review of systems
billing, E&M documentation guidelines, 95, 97 or whatever. Yeah.
But but I love the question because it goes to the root of the matter of, why do we even document? You
Why do
know,
we document? I'll tell you what was the thing that kind of got me excited about this so many years ago, and I missed the idea of them, is the Google glasses. So the funny thing is that Dr. Chrono, when I first signed up with them, had an early API with Google glasses,
yeah,
so that you would be wearing them and videoing the whatever you did with that patient. And I don't remember exactly what it was, but then I had this weird recollection that maybe there was like some in the sky person that was like transcribing what I said
yeah,
at the physical exam plus the video of it, and that was sort of going to create the medical record.
yeah,
But this whole like having to write things down is so 1983. Like it's
right,
painful. If you could just say, like, we could just use Descript on every one of your encounters and just be
yeah,
like, save bill. And by the way, I think I'm not going to say this because who knows, but like if you got audited, the information's there,
right,
right? Like if you were smart enough to say out loud, I see blah 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 blah,
yeah,
like on the medial portion of their left ankle, there's
yeah,
a one by if you were super descriptive,
yeah.
it could just be the medical record.
Yeah, well, and there is the like the Amazon Mechanical Turk version of this, which is
Yeah.
that these scribe companies have evolved to allow a remote scribe to basically listen in or watch your conversation and document real time.
Are they
Uh,
working in the COVID era? Are
uh,
Turks out there? I
I,
can't see
I,
why not. Well,
I
think
don't
of
know.
places where those would be happening.
Yeah,
I don't think a lot of the people have those technology in their home.
yeah.
They probably have to go to a place
Well, I
to
don't know. We'll
get
see.
a Turk.
I
You'll,
haven't explored that, but that would be an interesting thing. But
yeah.
ultimately, what I liked about Athena, even though it's more expensive in the right way, which is, Athena's model is they take a percent of your collections, and that makes sense to me because then the incentives are aligned. They
As
make more
opposed,
money,
as opposed to
just a flat monthly
flat,
rate.
right?
Yeah.
Okay.
I mean, I love flat rates, uh, but in an art, what I've learned in all the revenue cycle work that I've done is that the amount you get out is directly proportional to what you put into it. And so you have to be incentivized to do more work as a revenue cycle management company. Otherwise, you're just going to do the minimal acceptable amount, right?
Right.
So if there is a $20 claim or delta that needs to be worked, is the revenue cycle team incentivized to work it? They might not be if they're just getting a flat payment. But if they're getting, let's say 6%, it might be worth it to them. So I always like the vendors' incentives to be aligned completely or as completely as possible with the client. And
Let me ask a question. So it's a percentage of collections, not a percentage of billables. So right, like that is always kind of
I believe so. That's my understanding.
so that's important to understand
Yeah,
because there are ways that you can get it yourself into a little bit of a pickle, right? Where if
absolutely.
we actually know on the RPM side that if we take somebody and they start doing RPM, the vendor for RPM is going to bill them as a percentage of allowables,
Right.
not as a percentage of collections. So,
Well, I'm
well,
not even sure it's percent. Like with AccuHealth, it's just a
no, no,
flat rate.
it's
Yeah.
right, the flat rate, but it
Yeah.
doesn't matter if the provider is
Correct.
able to collect that money. You still
Right.
got to pay your bills.
Right.
So that is a very different model on
Yeah.
the RCM side that
Yeah.
I kind of find to be more pleasant because it puts everybody at risk.
Yep. Yep. And so I really liked that. And there were a few other things that really stood out. But the one thing that I was really surprised by and I don't like about Athena, uh,
Ooh, maybe they'll change it today. Just kidding.
no, I mean, is that they're telling me, it takes a month or two to get set up. And
That makes no
because
sense.
well, I think it's because they manage all the revenue cycle. They got to set up the bank account that they have access
Yeah, but
to, and
why
all.
can't you just start seeing patients right
I
now
know,
and start
I
documenting?
know. Believe me, I have heckled them and harassed them as much as I feel, as much as I can, to say, like, dude, I am somebody with
Spit in your
almost,
salad later.
I have zero patience, and so I'm working with them to try to get this up and running as fast as possible. But um,
So that's a bottleneck for you.
that,
Like,
yeah. So what I've decided to do is um, to start to build my own little minimal viable product solution until we can get um, Athena set up. And, given the current relaxation of rules, I can basically Skype with the seniors, just document in some HIPAA compliant,
Google Form,
solution.
whatever,
Yeah,
internal, yeah. Sign a
yeah.
PA with yourself.
Right. And then once Athena is live, then I can just manually transfer over in a number of ways, and then bill. So my billing is going to get delayed, but I'm okay with that.
Yeah.
So anyways, that's the current plan.
All right.
But where
Keep going.
okay, anything else on the EMR? Do you have any questions on the
Well,
EMR
yeah, I
side?
mean, so you didn't make a decision for the EMR based on a built-in telemed solution. So that's what I'm trying to figure
No.
out.
Okay, so here, the most important thing for me on the telemedicine, on like the video component, is what is the patient experience? Because if the
Oh my God,
experience
let's
is
talk
not
about this
easy,
for a long time. Let's talk about
yeah,
this. Wow. Yeah.
if the experience is not easy, you're simply not going to get the engagement you need. And so I actually spent a lot of time with them going through the different telemedicine solutions that plug into them, including Doxy and Chiron. And those are the two that I like the most. And it was super important to me that, to whatever degree possible, patients not need to manage logins and passwords and that sort of stuff in order to
Because of
do
the
their
patient
visit.
population you're also going to be dealing with. And Alex,
Yeah.
you and I are obsessed with user experience. Like,
Yes.
the user experience, because the user experience is not just your experience, it's
Yeah.
their experience. And I have of recent been involved with a rollout of something that had a 90% fail rate, because the end user, whether they be a CNA at a nursing home, at an assisted living, or the patient's
Yeah.
representative, if that in and of itself is poor, you're going to end up
Yeah.
falling on FaceTime. Like, you end up
Yeah.
like reverting back to just like the easiest possible thing, which is legal
Yeah.
today, but not necessarily in a really useful way. And just thinking back to, my experience in the telemedicine world is, I was involved with that study where we actually had to send out a telepresenter,
Yeah.
like an actual human being, to like set up the equipment or set up the even
Yeah.
the life. I mean, any part of that has friction is going to just bomb your practice, because
Yeah.
if that's the only way that you're going to succeed, is if you can get into their world.
Yeah. And so I liked what I saw with and like Doxy.me.
Yeah.
Um, they have a way for patients to access without needing to put in a login. There's pros and cons to it, because you want to make sure you know who this person is, it's verified, it's them, get their insurance info and all that. Yet you still also want to just have the encounter. And the other thing that was important to me was to make sure that people can self-schedule um, their encounters. And so that is actually pretty well done through Athena and Chiron. They have a whole system where people can self-schedule. So I haven't decided whether I'm going to use the Chiron or
Doxy,
Doxy or
Chiron.
something else. So more to be tested out there. Um, or do we just do like
FaceTime
FaceTime
and
for
Skype until
now,
the world
right? And
until the
just
world
document
works.
it, Athena. So yeah, so we'll see. We'll see.
Okay, so that's actually interesting. But the thing that you just brought up, which we can talk about the telemed solution issue forever and ever, but just quickly, as part of starting a new practice, and if you're a senior or somebody who has Medicare, you, Alex, in your new practice have to make sure it's a Medicare product that you accept, because you're only going to be accepting original
That's right.
Medicare. So it can't just be anybody. You have to then have a separate system, at this point, because you're not going to have your EMR, which could do insurance checking, but you now have to find another way to make sure that they even have the insurance that you accept, which is yet
Right.
another step, which sort of delays. It's a friction point. Hi, hang on a second. What's your Medicare number? I got to look you up to
Yeah.
make sure we accept your insurance. It doesn't feel seamless. And obviously this patient population, you're not going to be like, type in your Medicare number,
Yeah.
like you might have to make that part of your visit to kind
Yeah.
of, it's just going to have to be part of the experience of the visit.
Yeah.
Or
So that is actually
I
one
don't
of
know
my
if I read
questions.
that. I
How
don't know.
does one know if a patient is original Medicare or Medicare Advantage, or even has Medicare, period?
Okay, so you have to, there's a couple of ways. Medicare allows you on a patient, okay, unless you have a whole other system set up, Medicare allows you to call in or log in to check people one by one.
And you can do this through this, what website do you?
Correct. There is a way to do it. You have to, of course, there's another login and password that you
Yeah.
have to set this up. And I don't know if you can do it on a weekend, but there are companies out there.
Wait. Why would you not be able to do it on a weekend?
I don't know.
There must be some bureaucratic
Random. I
BS
don't know
rule.
why I would say that, but like I sort of feel like there may be a phone call involved. But
Yeah.
assuming that you also now do not yet have your Medicare ID number,
Yeah.
like I don't know if you could do that. But there's third-party companies that have, they can look inside the system and grab that information. They can grab a lot of information actually,
Right.
because Medicare, I think it's called the HETS system, the HET system, or whatever it is. There's a certain number of fields that you can pull out of Medicare for every single patient. It's not always the information that you need or want, but
Right.
it is a certain limited number of like data points. They include what type of Medicare they have, if they have a secondary payer that's been coordinated, you'll find out that information. You can find out if
so you could have a secondary insurance that's not coordinated?
Correct.
What?
Right.
Why? How?
Because when you sign up as a patient, if you sign up for Medicare and you don't coordinate your benefits, meaning like if you don't tell Medicare that you have a secondary insurer, Medicare will never look to that secondary insurance company to grab your secondary payment. And so you end up only getting paid the 80%. And then the patient is sitting here going, why are you billing me? Why are you billing me for that other 20%? But it's really on them. They didn't coordinate their benefits to tell Medicare, oh, look to United, look to Care First, look to whoever. It's just like one of those phenomenons of non-coordinated benefits. It's on the patient to call Medicare and coordinate that. So that's actually a process that you have very little control over. And in the revenue cycle management, like when I first started my practice, this was a thing. Like my biller would be like, oh, well, you didn't get the 20%, which in some cases is $40, $50, depending upon all the stuff that might happen. You're not collecting that. That's not insignificant. And he would then call the patient for me and they'd say, oh, but I have United. And he'd say, but Medicare doesn't know you have United. And because you, Alex, do not have to individually, you don't have to participate with Care First or Blue Cross or United or Aetna or whatever. There are private insurance companies. Medicare has said, if you are a Medicare provider, you do not then also have to participate in the private insurance market. You don't have to be in that market to get the secondary payment. So even though you're only a Medicare provider,
keep going.
Even though you're only a Medicare provider, it doesn't really affect your ability to collect the secondaries, even though they're obviously going to be in the private insurance space. So if the patient doesn't coordinate their benefits, you're never going to collect it. So as part of your RCM, you're going to continue to look for those deltas of who's missing that extra secondary insurance. And then you may have to somehow like create some system, if you want to be fully automated, where you can have an email go out to maybe a representative. Although in that patient population, it's sort of hard to know if they're even going to respond. That may be like those warm touches outside of your self-closed bubble that you want to create that may interfere with that, where you have to say, hey, listen, I don't want to bill you the $40 because I know you have a secondary. So that's
one thing I need to explore with Athena, because I know they have some sort of eligibility check that you can do at the beginning. So
Right.
to
That's
what? Yeah,
your thing. Yeah.
yeah.
And then, but in addition to the information that comes out about your, what they're, whether or not they're in original Part B or a Medicare Advantage plan, whether or not they have a secondary insurance that's been coordinated, is information like this. You can find out if they have accessed in the past or currently are in a Medicare Part A home health program, whether they are currently involved in hospice, whether they have had a lot of those preventive health codes are all sort of built into that. So you're going to find out when their last annual wellness visit was billed. And it should be pretty real time, but of course, this is very important. Most of the Medicare Part B, at least on the Part B side, I don't know about Part A, but on the Part B side, you have 364 days as a provider to submit your bill, which means you could have done this annual wellness visit, let's just say, and this is what's crazy, you may have done the annual wellness visit 364 days ago and still submit it today and get paid for it. But the crazy thing is, because that is a first come, first serve, if you did it 364 days ago and didn't bill for it, if you, Alex, did it on the 363rd day and did submit it, you will get credit for it and not the guy who did it last year because, hey, listen, sorry, you didn't fill out your, you
So
didn't
first to bill, not first to do.
First to bill.
Yeah.
And that's the same, and that applies also with chronic care management codes and RPM codes. So if you get to the table first, you win, because only one provider can bill for certain stuff. So again, back to the information that you can pull out of Medicare, it's it's the preventive medicine, the preventive codes as well.
So just to be clear, you don't need to enroll in the private payers to get payment for secondary insurance as long as the benefits are coordinated. But you do need to enroll in the private payers if you want to be reimbursed for Medicare Advantage, their MA plans.
Most of the time. There are some weird situations, like I think Cigna PPO. I think if you call them, you don't have to enroll, but like you can get you can get permission to see their patients for X amount of time, but that's just
I want things to be streamlined.
The friction is too great to, and the risk is too high. Like you almost have to be like, I'll try one and I'll see if I get paid. And if I don't, but then now you've established a patient, physician relationship with that person. And then that's just sort of feels terrible. You have to go back and be like, guess what? Sorry, your insurance stinks for what we're trying to accomplish. Maybe it's awesome for other stuff, but that's why you got to kind of keep this stuff very clean. If you don't want to have a massive entourage that surrounds you, you really can't do that.
Yeah.
It makes you have to create a box and say, I'm sorry to lots of people, but luckily we live in a state where the utilization of Medicare, I mean, in our state, but that doesn't matter because you're going to be doing this in a lot of places. But in Maryland, it's only like 10% of people have Medicare Advantage. So you kind of are like, ooh, if you had to roll the dice and advertise, that your hit rate's going to be pretty high. Like every person who comes to you is pretty much going to be a successful client / patient.
Right.
From an insurance perspective.
Right.
So yeah.
Awesome.
So you're going to have that third party that reaches into the Medicare system and pulls it out. And I know that Medicare probably has it on a patient by patient basis, but I'm kind of a fan of some of these third party stuff because they present it in a way that looks really nice and it's easy to understand. But there's lots of different ways to do that, and it's not as complicated as other things.
Right. Awesome. Let's move on to employees. This is
against everything we wanted.
Well, not office employees, but clinical employees, right? Yes. But any sort of employee is going to create headache and whatever. But for me, from the perspective of being able to scale anything I do, I don't want this business to 100% rely on me staffing every visit, right? So I have to have some clinical employees to help see some of the visits. So first of all, what I didn't realize going into this was that physician employee / partners would jack up the med mal rate extremely high relative to the employees being just
by factors of 10 and by 10 to
yeah,
1, 10 to the 2.
it's kind of crazy.
It's crazy.
So just because of that issue, I decided I'm not going to employ any other physicians. It's just going to
Cause
be
a tear to fall from my face. I'm kidding.
just PAs and NPs, so NPPs or APPs. And so that was an interesting point. And then then there's a discussion of should it be only NPs, only PAs, a mix. So Amy, you've employed NPs and PAs in the past. So talk to us
Yeah.
about this issue.
So I think, it's funny because when I first started my practice, I, as an emergency physician, really at the time that I was starting the practice, nurse practitioners were not a part of emergency medicine. I mean, I think they are much more commonly now. This is 10 years later. So I was really familiar with how PAs practiced medicine, sort of how they were trained, how they interfaced with me, how they would interface with me. And I was really comfortable with that. In the state of Maryland, you can only attach yourself to 4 PAs. But the important thing is that there was a very clear line of I had to create a delegation agreement, which meant that I would say, this person is sort of operating under my licensure. I am allowing for them under my, not license, that sounds wrong, but under my, I guess maybe it is my license. I am delegating to them certain powers that they can do in the state of Maryland,
right,
on behalf of me, but they're their own NPI number. So, I mean, they can, I think, in some theories get sued separately, but really if they get sued, I get sued.
right.
And it was just very clear to me sort of how they interfaced with me. It's not an independent relationship. It is something that, you want to make sure that you have if you ever kind of got yourself into a pickle, you would have to say, well, yeah, I mean, I am in constant contact with them. They know how to get me. If I ever go out of town, there is an alternate physician, or I take all my calls no matter what. I mean, it's a 24/7 you have to be sort of available to them.
Right.
Or at least clearly delineate how they will get in touch with you.
So talk to me about what you need in terms of, do you need like a collaboration agreement?
Yeah, it's called a delegation agreement in the state of Maryland, and
okay.
forms are available on the Board of Physicians website.
Oh, so it's a standard thing.
You don't need to,
standard. Okay.
Yeah, and you basically have to you basically say these are the tasks that this person can do. Mm-hmm. And that includes writing for narcotics. But we actually had, I think, a step backwards in Maryland, where I think now your name might need to be on any narcotic scripts. I know we're not always going to be sort of focused on that, but like there are like little weird limitations, but they can write for narcotics.
So wait, so this sort of delegation agreement, that would be required for regardless of NP or PA?
No, it's only for PAs.
Only for PA.
Maryland NPs have very independent.
I see.
They exist in the same capacity as a physician. I mean, they can start their own practices and operate very independently without any delegation agreement.
Even if the NP works underneath my umbrella organization, I don't need a delegation agreement?
You do not. Correct.
Okay.
They used to need to have some sort of relationship with somebody. I don't think that exists anymore. I mean, I think they literally are kind of like independent providers with like no strings attached, and they can pretty much do everything that MDs and DOs do. And so from that perspective, they are really just operating at like kind of doing their own thing. There's really no ties back to the doc.
Yeah. Can I share with you my first experience with a PA?
Yeah.
I was in residency in Philly at Jefferson, and I was an intern, and I'd be on shift, right? And this more kind of mature woman, so how old am I? I'm 29, I guess, in my first year of residency, and this more mature woman, probably in her 40s, would walk up to me, and she'd have like a pile of charts, like 20 charts in her hand, and say, "Here, sign these," and I would sign them because she did it with such confidence. I was like, okay, fine.
I'm signing
And then
up.
about like 3 months into it, I go to my chairman and say, who is this woman who keeps coming up to me and telling me to sign charts? Who is this? And he's like, oh, that's our physician assistant, and she runs the fast track or whatever. He's like, you're not even reviewing the charts? I was like, I
You
have
told me to just sign here.
I have no idea.
That's all right. We're all guilty of that unfortunate situation.
And then but we never actually worked together. So I never really interacted with a PA. And then I started at Prince William Hospital as when I graduated residency as an attending. And my very first interaction with a PA was Jackie Kanka, one of these no BS, hilarious, very smart, awesome PA. She walks up to me and she something to the effect of like, who the hell are you? Sign my chart. And I was like, who are you? She's like, well, I'm the PA. I was like, what's a PA? What does a PA even do? I really had no idea. None.
It's really hard to get into PA school, by the way. So hard.
And it's gotten harder. They have to have like years of experience. It's actually harder.
Hours of experience. Do you understand? Most of the PAs are actually smarter than I ever was when I mean, the idea that I got into medical school with like, I know how to like do a science experiment. Like, I don't even know, like, it just, none of it makes sense.
Without a doubt, some of our PAs were better than some of our docs.
Oh yeah.
Yeah.
Absolutely.
Easy.
Badass. Yeah. Many of them super duper badass, and in the emergency department. And now they're in all parts of medicine. I mean, they're practicing very independently, as the second in command for a lot of surgeons and subspecialists and specialists. Yeah. And I mean, I think from that perspective, I mean, PAs have a totally different way of getting trained and of being trained. I mean, even though from a Medicare perspective, you're going to get paid 85% on the 80%, and they're also going to get 85% on the secondary payment. Right. They're paid the same. They kind of in many states have the same like scope of practice allowances. It turns out that they don't necessarily all have the same knowledge base. They don't have the same skill set or the same attitude.
Yeah.
I mean, things I actually know just because we're ER docs, but PAs who have been trained, many of them have had to go through the emergency room. And I think there's like a real penchant for emergency medicine style people in the world. Nurse practitioners are much more likely to be like, nurses, they come across from a nurse perspective, which is a very global view of the patient.
Yeah.
But I think, you and I probably go in a little bit more like, okay, what's your disposition before you ever even see the patient? You're like, we got to just figure out what the end of the story is. Like, in between is sort of like, oh, really? That's very fascinating. Because I know I'm going to do an ultrasound, a CT scan, and all these different things on you. And then you're going to leave, but I need to do all of those things. The nurse practitioner is often much more of a listener. That there's exceptions to every rule. But, it is a different way of doing stuff. From the purposes of a business owner, you have to say to yourself, how independent do I want my employees to be?
Yeah.
And I mean, obviously, we haven't really talked about 1099 or W-2 or any of that stuff. And we are not either accountants or lawyers, so we can't say anything. But you have to say to yourself, what is that relationship? Are they doing work at their own speed, or am I giving them the work to do? And so, I mean, over the years, through lots of conferences and stuff, did transfer all of my employees from contractors to W-2s because I felt like that was a more real company feel.
Sure.
And then I felt like they were really my employees.
Yeah.
But
it depends on the model, right?
Depends on your model. Yeah.
Yeah. Like if my folks can set their own hours and whatever, then maybe keep them 1099s.
Correct. You have a whole different way of looking at it, and then you have to look through that. Whatever your state.
Yeah. So talk to me about ratios.
In terms of patient ratios?
No, in terms of how many PAs/NPs, what if they're part-time? What if I have a certain number in Maryland? Does the ratio still apply to a different state like Virginia?
No, you can have four. I mean, it depends on the location. I'm pretty sure DC allows for 4 and Maryland allows for 4.
So if I have 4 PAs who are completely focused just on Maryland, then I could have 4 different PAs who are focused just on Virginia. Is that right?
I don't know what the rules are in Virginia in terms of the ratio.
Yeah, but let's assume
Assuming
it's
it's the
4-1.
yeah, no, I mean, you've got a medical license in Virginia, you can do whatever you're doing in Virginia. And in DC now, every one of those locations actually delineates the type of relationship and how you're supposed to maintain that relationship. As an example, my recollection is that in the District of Columbia, you have to do a quarterly review with every PA and have documented that quarterly review.
Right.
Like every quarter, you have to sit down with your PA and say, hey, let's go through your patients, how are you, evaluate their performance in some way, or maintain your relationship with them in some way. So you have to sort of figure out each state how that goes.
Right.
But in nurse practitioners, just to say, like, you don't have to do a lot of that. It's less friction. It's different style. But like I started off 1, 2, 3. When I started my practice, I had 3 PAs and no NPs. I didn't hire an NP until I came on with EMA.
What about, talk to me about how you used to pay your NPPs.
So when I first started, I mean, I couldn't, when you first started practice, you can't say, hey, listen, I'm going to pay you no matter what. Listen, we have no patients, I'm still going to pay you. So it was eat what you kill mentality. And I was paying people about 50% approximately of what I thought I would collect from that patient based on the Medicare collection. So 80% is what Medicare was going to pay of the Medicare allowable, and then 85% of that because they were a non-physician provider. So I would give them 50% of that 0.8 times 0.85, which is what 0.6 something, whatever, 60%. So I paid them 50% of the 60% of the 100% Medicare allowable. Follow that, people. So it ended up being, let's just say, $45, $50 per encounter, depending upon the code that I used.
Right.
But, you have to figure out, are you doing office-based codes, house call codes, whatever codes you're doing, you have to figure out what is appealing to that person, because Medicare has basically said for a physician at 100% of the Medicare allowable, assuming you get your full Medicare and your full secondary, it's about $100 take home pay per hour after you pay 50% overhead.
Right.
And so if you say, well, maybe NPs and PAs make half of that, which in this day and age, actually they're making like way more than that.
Right.
You may be paying like $60 per hour. I mean, you have to think about how you want to do it. I mean, I think the per encounter payment methodology is so much better.
Yeah.
The problem is that you can't pay people based on what you collect, because that's not how that's not how cash flow works. If you're a provider, you're like, well, I did this work last week, I want to be paid next week.
Right.
You can't wait to see. But from historical data, you do on the Medicare side, if you don't screw it up on the intake side and bring somebody in that's never going to pay / that doesn't really have the Medicare you accept, you can pretty much predict that you're going to get that 80%. And then you can leave that secondary payment maybe for like a bonus or something like that if they do a really good job, because you're going to be collecting, 85% on that 20%.
Right.
So you could leave that as like, bonuses and, other cool stuff that you want to get, swag. I don't know, like what you want to give them. You can
if you have a clean claim, how fast does Medicare typically pay?
14 days.
Just continuously running? Or is it like on Fridays or?
No, it's continuously running.
So how does it work? Like all of a sudden
you can batch it. I don't know how your RCM is going to work through Athena. Maybe they batch it, but the perfect scenario, and by the way, there are some amazing, and I have to figure out who has this, that if you send a claim in, that the secondary gets hit, I don't know when the secondary gets hit after the 14 days, but that it could actually cycle back to your EMR, and then EMR, if given permission, can text the patient if they have a like if
patient
there's a
responsibility.
Patient responsibility, whatever you want to call that, and that they can pay through they get a text message that says you owe $4.82. Click here, and it could literally go through Apple Pay. How would
Well,
that be?
yeah, the company Simply, Simplee. I remember
I remember
we
that.
would do that sort of thing on the emergency medicine and hospital side.
Yeah,
So,
not invented, but okay, yeah.
so what about so all of a sudden you see $1,000 been deposited. How do you know which claims
My
are
God.
being
Yeah.
paid?
So if your RCM system's good, it will figure it out, right? Like it'll actually say, okay, here's
Yeah,
the rows, and then it'll do it to this. But the EOB, it has to know the smart EOBs will hook up.
yeah.
But there's always going to be a time, especially at the beginning, where your secondary payers are going to send you a check.
Oh, mail.
Your EFTs for the secondary payers until you get that revenue cycle all figured out.
Wait. How do you get that set up?
So here's how it's going to go. You're going to see your first patient, and you're going to put a CPT code in your ICD-9 codes, and
Yeah,
you're going to send it off. Okay. Then
ICD-10.
Medicare. What'd you say?
ICD-10, not 9.
Oh my God.
Yeah.
ICD-10.
Right.
Thanks.
Yeah.
World Health Organ. Sorry. So your you could put ICD-9 codes and see what happens. That'll
Right.
bounce back. So you're going to send it off with your CPT and ICD-10 codes, and you're going to get 14 days later your account that you set up with Medicare, you are going to get the 80%. And then they're going to send that off to the secondary payer, and the secondary payer is going to be like, oh, great. Well, we pay, 100% of the secondary or 50% of the secondary. And to be quite honest with you, be careful, because with some non-physician providers, they pay a lower percentage because they're like, oh, we don't, right? So the patient responsibility could change based on the person that's doing it for the secondary side. But let's just pretend, whatever, the secondary payer is going to, decide to pay a certain amount of that secondary payment. And they're going to say, well, where do we send it? Like, we don't know. Like, you're a new provider, you're like somebody
Yeah.
new. And so, like, you're going to get a paper check.
So it doesn't go to the MAC and come from the MAC through
No,
a
you're going to literally get checks directly from the private insurers.
Oh, that's painful.
So what you have to do, what you have to do over time is on an ongoing basis, as you figure out who your patients have secondary insurance policies with, you then have to contact those individual insurance companies and be like, oh, can you send me your EFT form and set up your electronic fund transfer form for those individual secondary payers?
Oh, so then how does the, Athena, or the revenue cycle company even know whether the secondary paid or not? Somebody has to go back and reconcile everything.
Unless there's a different system in place, but that is the way experientially I have had to go through that. And that is why there's little worker bees sometimes in some of these offices, is to literally be like, link the EOB of the secondary payments. And sometimes you just go, you don't even, because by law you have to balance bill people. You almost have to do that.
Yeah.
But there may be a way where you could OCR it and figure out how to grab the patient, because they aggregate, right? Like sometimes you'll get a check like $2,000, right, from a secondary payer.
Yeah.
And then they and it's a thick mail packet, and you could scan them all in maybe and like pull relevant data. Okay, whatever. That's your thing, man.
I shouldn't be complaining, right? You're getting paid.
And that sucks.
I just hate inefficiency, right?
I know. And that is one of those things, because I don't know if you can even set up an EFT in advance if you've never even had a claim. You can't be like, hi, I'm NPI number this and that with this business. Can you set up an EFT? They're like, who the hell are you? No. Right. You almost have to wait until you have a claim that comes through and gets paid to you. And then I think you can go back through. So think of it like this. I think it's a one-time hit per secondary, and most people have kind of the same 10. Yeah.
I was looking up on the CMS website, like, hey, what is the reimbursement for this code in our region, right? Because it's all regional.
Yeah.
And you look it up on that website, on the CMS.
The one that you never remember the name of.
Yeah, CMS CPT website, whatever it is. And I just wanted to share that, like, I finally figured it out, because there isn't a column that says, physician reimbursement.
right?
Instead, I think it says
Non
non-facility.
non-facility fee. Yeah.
But that's like such BS, right? Like that's like going to a hamburger place and the hamburger is labeled not hot dog. Like just say it's a hamburger. Why are you saying it's not a hot dog? It could be any
Just
number
say
of other
it
things.
is. Well, that's the semantics of this. I mean, we're like fraught with dumb acronyms and
Yeah.
impossible to and people speak in tongue. It's nuts.
Right.
This whole thing is so much more difficult to figure out.
Well,
And
it's
but
always
now
one thing. It's one common theme, which is whoever's putting this garbage out is
no user
not thinking
experience
about the user experience.
doesn't give an S about the user experience.
Yeah.
Not care.
And
Correct.
then you would think that maybe if you could hover or click the title of the column, it would explain what it is. But of course not. No, you have to find some obscure PDF that explains what all these column headers mean. Come on, man.
Well,
Like, what
also,
is this?
funny thing about it is that if you go to the CMS CPT, whatever that thing
Yeah.
is, you would think that you could just click on it and get a great explanation of
Right.
what is that code? Where are the place of services that you can provide this code? All that stuff. It's like I don't even know where it is. You have to it's too much digging to get the information, and all people want to do is be a doctor.
Yeah.
Tell me what I'm supposed to do. I will be the technician that you always call me, right? Like doctors are not like the scientists that are solving the world's problems. We're like technicians for a set of algorithmic rules about how to treat different diseases. Like, aside from the art of medicine, whatever, just tell us what it is going to take to build code, this CPT code.
Yeah. And
just
then
tell me. Just freaking tell me, and I'll do that. Like,
exactly.
I want to be able to follow the rules.
Right. I mean, isn't that ridiculous?
Because
like,
now we walk around going, oh no, is the speed limit 60 or 45? Am I going to get a tip?
Yeah. So instead, you go to,
back.
like, just for me to learn the remote patient monitoring codes, I had to read probably
100
at
hours
least,
worth of stuff.
Yeah, 40 or 50 articles from different law firms who have tried to interpret the Medicare, the 1,000-page, discussion thing that they publish where they have all their commentary and all that stuff.
Right.
Just do what you said. Just put the rules. In order to build this code, you must do the 10 following things.
It's
period.
Really crazy, and it's not simple. So that takes me back to our first podcast that we ever did, which is just literally like, this is part A, this is part B, this is part D, and seriously, the feedback that we've gotten on that is like, we've never heard anybody aggregate it like that together. We've never like, because it's not, there's no place that just says this is what part A is from an outsider's perspective. It's only like when you sort of like find yourself in the middle of it. I don't even know that billers and coders understand some of this stuff. They just understand their little teeny tiny square, but the big picture gets lost. And for us, as people who may want to start a practice, you can't. You spend the whole time wondering if you're going to go to OIG jail, because you
Medicare jail.
Or the grab back, or the I did all this work and I accidentally did not know. I mean, there's no intentionality, right? So like there's some, like that's why there's these things called cert audits, which they just kind of ping you, send me one chart, and you're going to get those. As soon as you hit a certain level, you're going to get from Medicare, oh, you said you did this, send me your chart note. And then somebody is going to make sure that you documented A, B, C, and D. And that, if you don't respond to those, that seems to be like the big trigger for like a bigger kind of audit. But if you respond to those, I mean, they kind of say, oh, well, you should have done this, this, and that. I don't usually think they do a major pullback from that, but that's
clawback,
the fear. Clawback. I think most people live in fear of screwing it up. But Medicare should want more people to participate, make it clear to understand what the rules of the road are. It is weird, but okay, so can we do an Alex summary? We've got a business, an LLC, we've got an NPI number, a Medicare number, we've got your med mal insurance, you've got a choice of an EMR, a choice of your telemed, you've got a choice of how you're going to look people up to make sure that they have the right insurance. You have, what else did we talk about? We talked about, how to look up how much you're going to charge for each different code, but how do you decide if you're seeing the patient in their home? I think this is what we were talking about is now you're doing telemed. How do you decide if this is a office-based code or is this a house call code? Because you're seeing the patient.
Or an urgent care code.
Or a which code?
Or an urgent care
Oh,
code.
an urgent care code. Yeah. No, I mean, I think there's
Because we're going to be kind of focused on this kind of minor urgent care / basic primary care space.
right. But
Kind
you're
of a
going to
great,
want to bring in some primary care services that they
yeah,
may not have been getting from their other
right,
doctor. Even if that other doctor is well intentioned, of course, because of the complexification of everything, they're
yeah,
not getting some of their preventive medicine stuff.
yeah,
How do you know? I think there's going to be a lot of trial and error, to be
yeah,
straight honest with you. I think you're going to throw out a bunch of CPT codes and say, I did all this stuff, see
yeah,
if Medicare pays you, and that's it. It's like test coding. I
yeah.
think you have to test code a lot of stuff.
Well, we settled on the idea that we'll start with the office-based codes. That
Yeah,
seems like the
office space.
safest
That
place to,
makes sense. It
yeah.
does make sense.
I do want to
It's a
say,
bedbound patient,
yeah,
unless it's a bedbound patient which meets homebound criteria, I think you could then use a house call code.
in the current kind of emergency
Yeah,
use
exactly.
period.
Right.
I do want to say that although we're criticizing CMS for that CPT lookup page,
It's
at
actually
least, well, at least it exists, right? Like you can't go on Care First right now and look up whether they reimburse remote patient monitoring.
not only that, but in my current sort of world that I'm in, there's a lot of questions about, does Care First pay for advanced care planning? And I have no idea how I'm going to do that. I
Isn't
have
that
no idea.
crazy? They're the
You can't
biggest
just call
payer in
someone
our
and say,
area.
yeah, right. I
The
know.
biggest payer in our area. They have what, 1 or 2 million members here. The year is 2020, and we can't look up whether this mega payer reimburses a certain common code. Like what? Get
Not
your
only that,
act
but
together.
Medicaid either. Well, although Medicaid might be a little easier to look up, but still, there's always a caveat. Like you maybe even if they did have it, that there's going to be some hidden small
Yeah.
print somewhere that goes, oh, except for.
Yeah. Now, and I'll tell you this, I found out Care First does not reimburse for remote patient monitoring, but not because I was able to look it up, but I have a friend who called the CMO and that was the only way to find out. Like, what? This
Wait,
is,
so if you have Care First as a
yeah,
primary, not Medicare, so Care First,
yeah,
it will not pay for RPM.
remote patient monitoring. Nope. That's what I am
Crazy.
told. That's what I am told.
So I
They
guess
have their own remote patient monitoring program. So Care First, what I've read is they chose some vendor, so they're using some vendor to do it on their own for like post-discharge
totally
high-risk patients.
They're just doing
Yeah.
it totally at risk.
But if you as a primary care doctor want to do that with the rules, with the CPT codes for, that have been established by Medicare, even though a lot of the private payers typically mimic what Medicare does, in this specific situation,
right, count on nothing. Count on nothing. Right. No, that old adage of like, well, if Medicare does it, I'm sure the private payers will follow.
Not necessarily.
Oh my gosh.
Well, thank you so much for all of your help in this kind of initial phase, and we're gonna share stories as I try to go.
Like every day is going to be a new adventure.
Yeah, we kind of do this and build this practice from scratch.
All right. Bye,
All right.
Alex.
Bye.
Bye.